Hello and welcome to Everyday Oral Surgery. This is your host, Dr. Grant Stuckey. I am an oral and maxillofacial surgeon practicing in Denver, Colorado. The goal of this podcast is to connect, learn, and inspire. In this podcast, you'll be hearing from OMS surgeons all over the globe discussing ways to improve the practice of oral and maxillofacial surgery. Most information shared in this podcast will be based on personal experience and opinions, so please supplement what you learn here with approved research studies. Without further ado, please enjoy today's episode. All right, everyone. Thank you for tuning in. Welcome to another episode. Today I'm with Drs. Andrew Jenzer. He's a repeat guest on the podcast, coming to us from North Carolina. We're also with Dr. Maxwell Lloyd, and he is an hemonc specialist in Boston. That's very exciting. First time we're having a hematology oncology specialist with us. So thank you. And thanks to Dr. Jenzer for setting this up. Maybe you could start us off here, Andrew.
Yeah. Good to be back, team. I am incredibly excited because joining us today is my best friend, my better half, Max. He's my brother. He's my little brother. He is kind of like a much better version of me in that he is much more handsome, much more smart, and my favorite person in the world. And he's also a second-year fellow doing hematology oncology up in Boston. So what better person to bring on as we start kind of a series of episodes looking at the topic of hematology?
Yes.
You want to say hi and tell the world about yourself a little bit?
That's much too kind. I've been spending many years just trying to keep up with Andrew in terms of his accomplishments, always pushing things forward. But it's such a pleasure to be here this morning. Thankfully, we could finally get this together and talk about some hemostasis and coagulopathy today.
Yeah. And our brief normal disclaimer, folks, please take everything you hear on this podcast as opinion and verify everything for yourself. Some of this will involve some opinions as well as we work through these topics. And just for everybody listening, Max's specialty is really breast oncology. He's really focusing on that, probably going to do his career in kind of that space. So not a hematologist exactly, focuses a little bit more on the onc side, but, he sees these things. If listeners, if you're not familiar, to do a fellowship in hemonc, first year trained in internal medicine. So they're very well-rounded, very smart doctors. Grant, you want to jump into it and start things off?
Before we start, did you want to mention your upcoming course?
Yes, thank you. We're recording this in kind of early mid-December of 2024. Each year over the last few years, I've been doing a kind of mock boards course, and that is geared at anybody who is interested, including all residents of any year, as well as folks gearing up to take the board examination, the oral board examination. And I was doing this for the military only the last couple of years, but have kind of broadened it. So pretty much for an entire weekend, and it's going to be January 11th and 12th, all day, Saturday and Sunday. It's all over Zoom. It's all free. You just have to log in, and then we'll let folks do mock cases. Every hour, I have a different faculty member come on. Most of them are program directors, fellowship-trained folks, frequent guests of the podcast, Grant, Matt Fahm, Ben Heckler, a few others. So my goal with this is I always, as a resident, wanted a chance to really better understand mock boards and what the finish line looked like. So now I'm at a position where I can, by calling some friends, give that experience to folks. So if you're interested in that, my Gmail will be in the show notes. Please just shoot me an email. I'm happy to send you the details, the login links, but I think it's a nice thing and hopefully will help residents kind of develop perspective about the upcoming board exam, see all different types of mock cases from all different perspectives and some amazing educators. And, if you're getting ready to take the exam, just some extra repetitions. And just a quick disclaimer, it's not associated in any way with A-bombs. This is just a weekend of mock cases from a lot of my friends and the best folks that I know.
It's fantastic. That's a great service to be offering. They need to sign up by what date?
There's no sign up. There's no date. You can just log in and out that weekend as you please.
Okay.
I make it as easy as possible. Take kind of case volunteers. There's no commitment. So it's literally just a come one, come all for any little bit or all of it that you want.
That is terrific. And then I'll put your contact info and link in the show notes for our listeners that are interested in that.
Great. Today, we're starting a multi-episode series on blood and everything blood related. And so Max and I wanted to start with some of the basics, kind of some doctor vocabulary like we usually start with, go through some basic kind of hemostasis and the coagulation cascade, testing for that, as well as some basic diseases kind of around that, and then explore a couple things, different trials and some fibrinolytic and special agents kind of in that. Each of these episodes will focus on a different area, trying to tackle the entire topic. It's not quite 6 seasons in a movie, but it's close. Max and I are both big Community fans, so you'll hear references sprinkled in throughout. But I wanted to start off with, again, just kind of some terms and doctor vocabulary. So particularly when we're talking about blood, also other disease processes and organ systems, as words that end in emia, E-M-I-A, and that really means in the blood. So some examples, include anemia, right? Lack of red blood cells, hypoxemia, lack of oxygen in our blood, methemoglobinemia. So when you hear something that ends in emia, it refers to specifically in the blood. Now, as we kind of progress and go through some of these, we're talking very generally and basic. There are many more specific, specialized workups and panels when it comes to these disease processes, things that can vary by hospital and by specialist. So the bottom line, kind of like our normal listeners will know, if you're working up a patient for surgery or caring for them that has especially one of these conditions, consult and talk with their managing provider, whether that's a hematologist or an internal medicine doc, because every patient is different and that emphasis on communication is really key. And, a great place to start. Well, what is blood? How do we kind of think about it and define it? Is it a solution, a suspension, a colloid? And the answer is that blood is actually a colloidal solution that behaves partially like a suspension. Kind of complicated, but if we break down each part, we can kind of think about what's in it. So why is it technically a solution, a colloidal solution? And it's because it has substances like sodium and chloride that are dissolved in it. It's a colloid because we have macromolecules, all the various proteins. And it's technically a suspension because if we let it stand for some times, we will see and realize sedimentation. Like we have red blood cells suspended in the plasma. And inside blood, we have the plasma component, red blood cells, white blood cells, and platelets. Max, do you have any other insights or, some basic framework for thinking about blood?
No, I think that was a really great framework for thinking about blood, the underlying components, and sort of helps start our approach to thinking about some of the underlying terminology and then conditions associated.
Yeah, and I know it really helps me to think those specific entities of the plasma, the red blood cells, white blood cells, and platelets, because then when you get deeper down and you start to think about replacement therapy for one or some of those agents, then having that framework helps delineate what they're missing and what you need to replace. Max, you want to kind of take us through, how you think about the steps in primary hemostasis?
Absolutely. So primary hemostasis, which we'll contrast against secondary hemostasis in a minute, is the initial formation of a clot. So it's really creating a platelet plug. And there are 4 primary phases. You have your vasoconstriction, platelet adhesion, platelet activation, and then platelet aggregation. And it's a complicated process. There are many individual steps with multiple G protein receptors involved, as well as von Willebrand factor. I think not getting into the nitty-gritty details, but just knowing that there are several conditions associated with pathology in those individual steps along the way. So you may have heard of a condition like Glanzmann's or Bernard-Solier. Those are conditions related to mutations that can disrupt primary hemostasis and lead to issues with forming that initial platelet plug, leading to bleeding. So really that primary hemostasis process is the initial platelet plug that forms that then allows secondary hemostasis to start, kicking off the coagulation cascade, which, Andrew, do you want to take back over?
Yeah, I think about previous studying for the CBSE and all those specific mutations that result in some of the things you said, like Glanzmann's, thrombocythemia. I would imagine those are pretty rare. Do you ever come across some of those weird initial diseases in the primary hemostasis? Or are they pretty unusual even in kind of your world, unless you're a hematologist who deals with that kind of subset specifically?
I think that in clinical practice, these conditions are quite rare, where I have never taken care of a patient with either of those conditions. And you may see them during a career, especially as a subspecialized hematologist. But in general, I think that they're fairly rare in the population.
Yeah, I wonder if it would be like we would do surgery on somebody with one of those, like, again, like once in a career kind of thing. Definitely would review everything about the pathophysiology and talk to the hematologist before I would do surgery on somebody like that. But yes, so this brings us into something more familiar, the secondary hemostasis, the good old coagulation cascade. For residents and learners out there, I would say that this is something you need to know cold, being able to speak about it backwards and forwards, being able to draw it out, and just spend time learning, because if you have a super good foundation of it, it informs all the various medications that you're going to have to understand and how those affect it. Without that initial framework, this gets real hard to understand. So make sure you can draw it out on a whiteboard. There's some different ways to think about it. We have the intrinsic and the extrinsic pathways. The intrinsic, I remember, is a little bit longer. 12, 11, 9, 10, 8 kind of feeds into 10. And I think about a soccer team, football if you're from Europe, but in soccer, 10 is the midfielder, right? The field general directing everything. And everything kind of feeds into 10. The extrinsic side that also feeds into 10 starts with factor 7, which is found in tissue, hence it being extrinsic. And then at 10, with that midfielder in soccer, it kind of starts the common pathway, which is 10, factor 5, and then 2, and then 1. We have some other things in there, like factor 13 helps stabilize the clot. Factor 4 is technically calcium. So the ones that you don't commonly see or hear are numbers. They are mixed in and important in just smaller ways. Max, do you have any other helpful mnemonics for thinking about this, or things you can fall back on mentally for it?
Yeah, I think that the soccer analogy is great. I've also heard that you can think about the lower denominations of US currency counting down in terms of the bills. So you have a 10, 5, 2, and then 1 as the US currency in decreasing order is one of the ways that I've thought about thinking about it.
Awesome. And I think it's worth mentioning too that generally for these primary hemostasis disorders, these really rare ones, you would often see things like mucocutaneous bleeding and maybe some petechiae versus these secondary hemostasis disorders. And we'll talk about these. These, if they have problems and disorders in the coagulation cascade, then they often will present with deeper tissue bleeding, joint bleeding, or some other issues like that. Grant, I don't know, is this digging up some memories, both of the, starting to jog some of the bleeding disorder things and the coagulation cascade?
For sure. This is some good stuff to rerun through. As far as intrinsic pathway, extrinsic, the common pathway, the various factors involved, I mean, is this mostly for testing purposes, or is there any clinical application here that can really come in on a daily basis when you're dealing with patients with these issues?
I really think so. When I'm caring in the perioperative setting or working patients up who have any of these conditions, or they're on anticoagulation, like so many of our patients are, understanding what medicines they're on, be it dual antiplatelet therapy, direct oral anticoagulant, warfarin, understanding what factors are involved, how they're kind of turned off, informs parts of the decision-making process. Because in future episodes, and we're going to talk about, it's all about risk stratification, right? And how the hematologist and the medical side describes that risk, and then how we also determine the risk based on a surgical procedure, because determining that level of generally low, intermediate, high perioperative bleeding, their risk of having a thromboembolism in the perioperative period, that's going to determine how we manage that anticoagulation, generally continuing, stopping, bridging, how long they should, be off of it after surgery and restart it. These are some major considerations. So having this kind of solid grasp really helps me when I'm thinking through those steps that I'm going to go through for individualized patient decisions. I think without that framework, it's very challenging to understand it. Not to say you can't review it, but having that kind of cold, and I don't know about you, Grant, but especially with older folks, so many of them are on some type of anticoagulation these days.
Yes, for sure. That's a helpful way to look at it.
So next up, there's the natural inhibition pathways of our body, which are equally as important to understand. How does the body turn off this coagulation system? Because otherwise we just have blood clots all the time and a lot of thromboembolic issues. So the main ones are proteins C and S. Those are made primarily by the liver. Protein C gets activated by the thrombomodulin thrombin complex. A little bit too detailed for off-the-cuff knowledge. And activated protein C then works with protein S as a cofactor to primarily turn off factors 5 and 8. So you can think about C and S as proteins that are the natural turn it off kind of pathway. And we also have plasminogen. Remember, something that ends in ogen is a zymogen or a proenzyme, something that is biologically inactive until it gets turned on. And once plasminogen gets cleaved and kind of turned on, it becomes plasmin. And plasmin breaks down clots. Now, we'll come back to this, but a point I want to hit is this is where TXA or tranexamic acid hits. It competitively inhibits binding of plasminogen to lysine receptors on fibrin, which prevent the activation of plasmin and the degradation of fibrin. So TXA helps us to preserve blood clots, stop bleeding. You can think about it. But that's the mechanism. It kind of prevents that conversion of plasminogen to plasmin. And we'll talk about that more, but it's such a common agent that we use these days. Again, really important to understand the mechanism for when we use things. I do want to hit some common questions. Like, what kind of questions do I ask residents about this kind of stuff? So very common, what factors are made in the liver? Most people mistakenly start to talk about the factors that are vitamin K dependent at this time. But you got to remember, it's all the factors are made in the liver, except for a couple. Factor 8 and additionally von Willebrand's factor, although that's a little bit of that primary side and separate from the coagulation cascade. Those are both made in the endothelial cells of the vasculature wall. But all the other coagulation factors are made in the liver. And that's why, previously, Grant, when we were talking about liver disease, when that advances into that severe stage, people tend to have wild coagulopathies. And I know Max is taking care of some of those patients. A slightly different question is, what factors are vitamin K dependent? And that answer is 2, 7, 9, 10, and protein C and S. So a little bit different there. And that's going to play a big role when we start talking about particularly warfarin, which inhibits that. So we'll get back to that. But vitamin K dependent factors, 2, 7, 9, 10, and protein C and S. Max, anything from your experience, particularly about maybe your experiences with those really sick liver patients and just as their livers go? I mean, I assume you have seen some just labs all over the place that are bouncing around and probably some severe bleeding issues with those folks.
Yes. When you have early stage and progressing into more advanced stage cirrhosis, one of the important labs that we monitor in those folks is the PT-INR. It's part of the MELD score, helps predict overall mortality and stratify really how sick some of these patients are. Cirrhosis can be particularly challenging because patients can be both predisposed to bleeding and clotting because of changes mediated by dysfunction in the liver. Often in earlier stage liver disease, we start to see prolongation of the PT. But when we get into more advanced stage cirrhosis, because as you had mentioned, most of those factors are made in the liver, we can really start to see abnormalities in the PTT and proclivities for bleeding as well.
Yeah, I think it's something, usually when Max, when we think about liver and kidney dysfunction patients, we're always thinking about how it's going to affect our regimen of sedation and the drug metabolism. But sometimes we forget that, hey, the liver is a major part of this whole coagulation system. So you should think about that as well. Max, can you start taking us through some testing stuff as we think about how do we look at some of this stuff from in terms of laboratory values?
Absolutely. So I think that with any blood disorder or thinking about the blood of a patient, the tried and true test that we always start with is a complete blood count or a CBC, often with a differential. And what the CBC does is it really measures the number and the size of the different blood cells, red blood cells, white blood cells, platelets. We get a sense of a patient's hemoglobin, their mean corpuscular volume, MCV, the size of the cells. And so it gives us great initial information about a patient's blood and some insights into any underlying pathology that might be there that needs additional investigation. The CBC can immediately tell you informative things like if the red blood cell count is low, my patient's anemic, but are the red blood cells microcytic, small, or macrocytic? Are they large? Are they hypochromic, suggesting a low hemoglobin, or are they normochromic? Do they have a high white blood cell count called leukocytosis? And if they do, can you look at the differential? Do you see a lot of neutrophils in a patient with active infection consistent with a reactive process? The bone marrow is doing its job, mobilizing those infection fighters and pumping them out into the peripheral circulation. Or do you see an increased number of circulating immature forms that might suggest that there's underlying pathology coming from the bone marrow and might be informative to do some additional testing? So I think that the CBC is critical to help inform what's going on with the patient, as well as additional, more specialized testing if we're thinking about hemostasis and coagulopathy, particularly with the prothrombin time, the PT, as well as the partial thromboplastin time, or PTT. Those are additional tests that we have in our arsenal to help start to identify what might be going on from a bleeding perspective in patients. And we can dive into those a little more specifically, but with the CBC, Andrew, any other pearls you wanted to highlight or questions that you think are important for our audience?
Yeah. For learners, and one of the best ways that I think I picked up from you, honestly, and a lot of other very smart doctors is diagnostic schema. Meaning when we see a particular thing, like on a complete blood count and other parts of the body for labs as well, when you see a lab value that's highly out of normal and even roughly out of the range of normal, how do you conceptualize and think through a framework of differential diagnosis? And things like isolated leukopenia or leukocytosis, right? If their white blood cells are really, really low and everything else is normal, I start thinking about things like HIV or other immune suppression conditions, weird things like cyclic neutropenia, infections like hepatitis. And I've had a number of patients that have recurrent facial infections and we can't figure out why. And turns out there's an underlying condition like that. Or conversely, they have a super high amount of white blood cells, 30,000, 40,000, 50,000. There's not huge lists of things that cause some of those things, but having an idea in your head as a starting point of what if it's super really high or low, and then what are the most common things, helped me conceptualize and build the framework for understanding more details. And I truly do apply that to the patients that I see in clinic. I don't know, Max, people in internal medicine, I would imagine, think in a similar manner.
Absolutely. I think that interpreting the lab values in the context of a schema is really an important way to approach a lot of these conditions. For example, if it's anemia, if it's microcytic or macrocytic or normocytic, what is the RBC indices? Those can take you down different diagnostic pathways that help narrow your testing and differential diagnosis of what is going on with the patient.
Awesome. And we're going to briefly touch on a lot of these things, but each one of these tiny little things can be hours of episodes and lectures. So there's a lot of good stuff that exists on podcasts, on YouTube, and you can Google it. But if you can find or think about when you start to learn some of this framework and as these diagnostic schema, I would highly encourage you as you're out there listening to do that. Let's talk about some bleeding tests. So Max, you mentioned it a little bit, and I kind of want to start, we're going to touch on the most common ones, prothrombin time or PT. So what is a PT time? PT measures how long it takes for a clot to form in a blood sample. And how is it actually done? Well, first we get a sample of the patient's blood from a venipuncture, and the blood is decalcified to prevent the clotting process from starting before testing. Remember, calcium is factor 4. It's part of this process. The blood cells are then separated from the liquid part, the plasma, by centrifuge. And the PT test is performed by adding the patient's plasma to some source of tissue factor. This tissue factor converts the prothrombin to thrombin, and the mixture is kept in a warm water bath at 37 degrees Celsius for 1 to 2 minutes. We get some calcium chloride added in order to counteract the sodium citrate and allow clotting to start. And then the test is timed from the addition of the calcium until the plasma clots. And this test is called the prothrombin time, or PT. Might sound a little academic. I think it's important to at least understand what we're actually doing once. So what does the PT look at? It measures the extrinsic pathway because tissue factor is what's used for the test. I really like one of my favorite mnemonics, and we'll come back to this as we discuss anticoagulation, is the word WEPT, W-E-P-T. And this stands for warfarin affects the extrinsic pathway. Kind of helps give you some insight into how warfarin works. It gives you some other mnemonics, though. Warfarin is measured by a PT. You just eliminate the letter E in the word WEPT. So extrinsic pathway, PT, warfarin, they're all lumped together in that one word. It'll give you that answer. Conversely, as we talk about PTT, you could think intrinsic pathway and heparin. So if you think WEPT, you can get 3 answers right there. Warfarin affects the extrinsic pathway. It's measured by a PT, and the extrinsic pathway is measured by a PT. A normal value for this is 10 to 13 seconds, but there are slight variations in different hospitals and regions. So this is why there is a calculation done and an adjustment giving us what is described as an international normalized ratio, or INR. And that is simply what that is. It's to account for those little differences so we can speak and communicate that patient's value and eliminate some of those regional differences. A normal INR in a healthy person is about 1.1 or less. A therapeutic range for anticoagulation in most patients is 2 to 3. But remember, this varies depending on their indication for anticoagulation. An example is mechanical heart valves might require a little bit of a higher INR. Any thoughts about that, Grant or Max? So PT, WEPT, measuring that, looking at warfarin?
No, I think those are just good things to be aware of, and what aspects of the pathways they affect, especially for us, like you're talking about heparin versus warfarin, and knowing how these tests are working and what they're acting on. Super important.
Yeah. Max, you want to add any comments and then take us through the next one, the sister test of the partial thromboplastin time?
Yeah, great review. The PT and extrinsic pathway. You mentioned that monitoring the INR in warfarin is the test of choice, and that goal of 2 to 3 is a range because really you're shooting for 2.5, but warfarin can have varied metabolism. It can be sometimes a difficult drug to dose, requires frequent monitoring to make sure patients are on the right dose. So you give a little bit of wiggle room, somewhere from 2 to 3. You hope that most of the time they're falling into a therapeutic range there. But just seeing enough patients when thinking about warfarin acting on the extrinsic, heparin on the intrinsic, eventually it sinks in. And when you see these folks in the hospital and see what labs are being used to monitor their therapeutic anticoagulation, it starts to coalesce into a logical picture. But the sister test, as you had mentioned, the PTT, or the partial thromboplastin time, is measuring the intrinsic pathway. So this test is performed in a similar manner as the PT test, except for instead of tissue factor being added, calcium and activating substances like cephalin and kaolin are added to the plasma to start the intrinsic pathway of the coagulation cascade. Normal time is about 35 seconds, and this is the pathway that's affected by heparin. And clinically, that's why in the hospital, if you see somebody on a heparin drip, they're going to be monitored with PTT levels. Sometimes if people have underlying conditions or other biochemical processes that make PTT monitoring unreliable. You can also use anti-10A levels to monitor heparin, but most of the time you'll see people getting PTT levels to make sure that their heparin is therapeutic.
I want to tack on a comment and jump ahead to just nail that, your last comment in people's minds. Anti-factor 10A levels are also pretty much one of the only things we can use to actually check on somebody who's on low molecular weight heparin, like enoxaparin, Lovenox. So we'll come back to that, but we're trying to put little pins and things on these details so you can hear it a bunch of times. I do want to get up on a little soapbox and talk about the D-Dimer test. This is something I hear misunderstood all the time, so let's try to clear it up for folks. So the D-Dimer test, what is it? It's a byproduct of blood clotting, and the breakdown process can be measured via analysis of a blood sample. And a D-dimer, it's released when a blood clot begins to break down. The platelets are connected to a D subunit when a clot forms. Many of these bind platelets together as part of the formation. So then as the clot breaks down, they're released. And so a D-dimer test has a very high sensitivity, but a low specificity for detecting pulmonary embolism or deep vein thrombosis, right? If you think about using the Wells criteria, an intermediate patient with a score of, somewhere off the top, like 3 to 7, you can get a D-dimer test. The thing that I really want to harp on is that, remember, there's so many things that can cause an elevated D-dimer. Things like pregnancy, malignancy, smoking cigarettes, trauma, infections, sepsis. Any type of inflammation, including surgery, makes this test unreliable. So when we're talking about patients in our world and they're on the floor after surgery a day or two, and you start to have concerns about a PE, right? Maybe they have some chest pain, tachypnea, hemoptysis. The D-dimer test is not something we're going to reach in our bag for. We're probably going to risk stratify them and use other modalities like bedside ultrasound if they have, clinical evidence of a PE and a deep vein thrombosis in the lower extremity, or getting a spiral CT of the chest, engaging our internal medicine colleagues to kind of help us. But that D-dimer test is great in a vacuum. But remember, almost anything that causes an insult and inflammation to the body will elevate that test. Do you guys have anything to add to that, Max? Any words or pearls of knowledge about the D-dimer? I just think recent surgery patients are probably not the best to measure in and make clinical decisions off of.
Often it's not a test that's going to cinch a diagnosis or be incredibly helpful, but sometimes it can help push you in one direction or another as just an additional clinical data point to help make decisions from. But like you said, it's not specific and can be elevated for a number of reasons, which makes its clinical utility sometimes limited depending on the scenario.
It's a common thing when I'm going through that, or when I'm giving mock board cases, trying to elucidate some of that. And usually people's answer is, "Oh, get a D-dimer." And I'm like, let's talk about that. So, all right, I'm going to get off my soapbox there, but hopefully we've talked about that. Max, can you talk us about, now we've defined kind of the PT and the PTT, mixing studies, good old mixing them together.
Yes. So mixing studies, we love. It's an incredibly helpful test to really start to understand what's going on in a patient with a bleeding disorder. So what you do to perform a mixing study is you take the patient's plasma and you also take normal pooled plasma and then you mix them and you remeasure their PTINR and PTT to see what happens and what changes when you add the normal pool plasma to the patient's plasma. So if you mix those together and the clotting time corrects, let's say the PT normalizes or the PTT normalizes, depending on what was initially elevated, that suggests that there could be a deficiency in the clotting factor that was corrected with supplementation. For example, if you had a patient with low factor 8 in a prolonged PTT, if you add normal plasma, then that value is going to correct and normalize. On the other hand, if the clotting time does not correct, that suggests the presence of a circulating factor inhibitor, because even though you're adding supplementation of the factor, you're adding the factor back, the inhibitor that's present in the patient's plasma is preventing normal coagulation. So if you had a patient with an acquired factor 8 inhibitor, they would still on initial testing have just a prolonged PTT, but when you do the mixing study, it doesn't correct. And you can use this especially as an initial test and then further testing for confirmation depending on your underlying suspicion. So you can look at specific factor levels, activity levels. You can also test for inhibitors. So in those cases, if you were worried about an issue with factor VIII, you could send a factor VIII activity level or look for a factor VIII inhibitor. And that can build off the initial mixing study, but can be really helpful in these folks as we're working down this testing pathway from getting a CBC, getting the PT-PTT, seeing that something is wrong and trying to narrow down on the specific issue at play.
You're just kitchen and chefing it up, mixing, huh?
That's right.
In terms of the last tests, before we start talking about some abnormalities and approaches to abnormalities, I do want to mention one thing that I do not have training in. It's a newer thing. I think it's not present at a lot, especially at smaller hospitals, but that is thrombal elastography. This is also referred to as TEG. And this is a non-invasive test that quantitatively measures the ability of whole blood to form a clot. It uses in vitro testing to measure dynamic changes in the viscoelastic properties of a blood clot under shear stress. Very cool. And from what I understand, it can be a real game changer, especially in conditions like a disseminated intravascular coagulopathy, where you're burning through all of your factors in different ways. You can get a real-time bedside little test to determine what the patient needs to be replenished. It can be extraordinarily helpful in resuscitation, DIC, and other kind of weird things. There are different types of TEG. Probably the most common is called ROTEM, and that is simply rotational thromboelastometry. So there's kind of different rotational and some other different names, different variations of TEG. And it really allows you to quantify alterations in either coagulation factors, platelets, or the fibrinolytic system in acute situations. From my understanding, you kind of take the blood sample, you centrifuge it, and it gives you a little graph, kind of bedside very quickly, usually 15 to 30 minutes, somewhere in that range. And that graph and the interpretation can help guide specific blood product therapy, like platelets versus FFP, and some other modes, just to mention for context, are things like XTEM instead of ROTEM. XTEM specifically looks at the extrinsic pathway. There's INTEM, which looks at the intrinsic pathway, and FibTEM, which looks at fibrin in that pathway. So I would recommend, if you are a resident, if you have the ability to get with somebody and see this or learn from them, it would be an amazing adjunct to have knowledge of. I just haven't had a chance to kind of play with it in real life in person. But yeah, I don't know if it's still mostly at major hospitals or you just see it in specific situations. I don't know. Grant, you ever heard of that? Max, you ever seen it around?
I don't have experience with this testing, just hasn't been something I've seen during my training, but certainly is an incredibly interesting approach.
Yeah, me neither. Good to hear about cool technology.
Yeah, little bedside graph. Yeah, so thromboelastography, ROTEM being the most common TEG, so check it out. Before we kind of move into the approach to the abnormalities, any thoughts on anything we mentioned with the various tests, Grant?
This is probably something we'll cover later on when we jump more into, the various anticoagulation medications. But you mentioned, that the INR therapeutic is 2 to 3, but sometimes they're running it higher for mechanical heart valves and other things like that. I mean, that would just be probably a clinical question, is like, what types of things is it usually running higher for? And for us, to be aware of what are situations where, like, if we send a med consult, the prescribing doctor would say, yeah, no, you really can't stop that. Anticoagulation is too dangerous to stop for whatever, tooth extractions or whatnot.
Yeah, we will dive deeply into this question because I think you really have to understand it as you're doing the combination risk stratification. But if they have like a more acute issue than somebody who really can't just be stopped and turned off, that we'll talk about and walk through bridging therapy and how we approach that and how we do that. And then even the harder, I think, thing to understand is when, how, and why to restart the anticoagulation afterward. Or like you're describing, like, hey, you really can't stop it in this patient for these multitude of reasons. Hey, let's get it done in a hospital. So yeah, we'll get deeply into that. Max, do you have any comments just from like the med consult side? Like, I know you're at a very specialized institution, so you're probably not seeing too many oral surgery consults or surgical kind of things, but I imagine you do see some surgical consults for other types of surgery, and tips on like how you convey information or what we can expect from the doctor about kind of the thought processes. Do you like to see really good consults that are thoughtful and long as opposed to need to take it out? Please advise.
It's always great to have as much open information and communication as possible, understanding that the idea of a consult, when you get a consult, it's colleagues reaching out for specialized expertise and really help. We want to talk about this case and get your guidance on what to do next. And I think that the discussion of anticoagulation management is incredibly nuanced and can often be patient-specific, scenario-specific, and details we could get into in depth when we talk about anticoagulation agents and management. Taking a step back and thinking about why the person is on a blood thinner to begin with is a critical place to start to think about what are the risks and benefits of stopping the anticoagulation. Can I do that safely? How long can I do that safely? And what is the urgency of the surgery? If somebody needs a surgery emergently, then we will do everything we can to minimize risks. But if they need to have surgery, they need to have surgery, and you do whatever you can perioperatively to support them through that. If a surgery is more elective, then you have a lot of time outside of the hospital, ideally, to start to plan around their anticoagulation and what to do leading up to the day of surgery. So sometimes, Andrew, as you had mentioned, this idea of bridging, if someone has an indication to be on something like warfarin or a DOAC that you really don't want to stop, could you bridge them with low molecular weight heparin, a Lovenox twice a day leading up to surgery that you would only need to stop for a few days before they go into the OR? Or is it somebody in the hospital that you need to bridge with something like a heparin drip, which is fast on, fast off? And you can ideally start within hours after the surgery's been completed when it's safe, if they had a really strong indication to be on a blood thinner for as much time as possible. Let's say they had a more recent DVT or PE. If somebody's had a blood clot, especially within the last 3 months, that puts them at much higher risk than somebody who had a blood clot, say, years ago. And so those factors are weighed in when we're trying to calculate what is this person's clotting risk? What am I really having them on the blood thinner for? And how confident do I feel it's safe to stop it, and for how long?
And I think that some of the sickest people when it comes to hematologic diseases, I've cared for kids with horrible sickle cell and other, all the multitude of disease processes we'll talk about, is in conjunction with, often their kids, like the PEDS hematology service, right? They get admitted to the hospital the day before, they get tuned up by the hematologist. I take their teeth out in the OR, keep an eye on their bleeding inpatient for a day after, make sure they don't have a sickle cell crisis, like in that example. But I think somebody maybe like you're describing, Max, too, with the super high risk of putting them in that category, it could be that too. Like they're either in the hospital or admitted, heparin drip, fast on, fast off. So even risk stratification with how we manage bridging, a lot of variable and variations. But yes, my hope, Grant, is to, we're going to dive into that in a whole episode, but the consult and the communication is so important. Please, listeners, do not just write, need to take out some teeth, advise about whatever. I usually write a thoughtful, almost soapish note and, hey, this is a 50-year-old male, past medical history, blah, blah, blah. I need to perform this type of surgery and take out X amount of teeth. This is a low or intermediate risk surgery. I expect it to take about 30 minutes. I usually would lose about 20 cc's of blood. I have these local hemostatic measures. From my understanding of the disease process and the chest guidelines or the guidelines for whatever, the CHADS 2 VASC, et cetera, this patient would be in the low to moderate. So from my point of view, I think it would be safe to continue or hold the medication, but I would appreciate your expert advice and guidance. because I'm hopefully showing the person I'm consulting that I at least have a rudimentary understanding of this and can be thoughtful about it to appreciate their point of view, which I would like to hope is good. It's the poop in, poop out concept, right? If we write a good consult, then, they're more likely to give you a good consult back and appreciate the collaborative work. I assume you see all different versions of that, Max. I don't know, is there any examples that stick out in your mind?
Yes. And at the end of the day, everybody is trying to do what's best for the patient and trying to do what's right for the patient. So even if you do get a brief or curt consult note, people are busy. People have a lot going on. And so always giving your colleagues the benefit of the doubt and some grace, especially in these complicated, challenging clinical scenarios, I think is also incredibly important. But we always appreciate, I think everybody appreciates, because often on the flip side, when we're reaching out about an oral concern, need to know if surgery is indicated, providing as much information as possible to you guys to understand if this is something that needs to happen in the hospital or if it can wait until outpatient follow-up is also incredibly important to frame the patient the right way so that we're all providing the best possible care in that moment.
I make all my junior residents bring their consult notes to me first, and then we go through them in detail. Because if I can do that for a few years, I can make them great consult writers. That's my goal.
That consult you gave, that brief example, is probably the best one I've ever heard. That was fantastic.
Yeah, we should all aspire to do that, team. Everybody listening, be a great consult writer. It takes a little bit extra time, but I think it can really provide better care for a patient on the back end. I really do. All right, Max, you want to take us through the approach to some abnormal lab values?
Yes. And just being a little bit mindful of time, I can move through this a little bit more quickly, but please jump in and stop me with any specific questions. I just wanted to give a framework that I have always thought was helpful when you have a patient with abnormal coagulation studies. As you were mentioning earlier, Andrew, sometimes it's nice to have a schema or a way to approach abnormal testing that can help narrow your differential diagnosis. So if you imagine sort of a 2x2 grid of thinking, is my PTT prolonged, my PT-INR prolonged, or are they both prolonged, or are neither prolonged? If you have an abnormal PTT in a normal PT-INR, that would suggest that something's going on with the intrinsic pathway, as we had discussed. And so first and foremost, what I always do when especially getting a consult, or if it's my patient and I see an abnormal PTT, normal PT-INR, check the med list. Sometimes it's right there. They're on a heparin drip, and that is the reason that those labs are abnormal. So always good to look at the medications. Am I giving them something that's causing this? The other things that you can be thinking about, as we had talked about, is there a factor deficiency, or is there an acquired factor inhibitor there that's causing this, which you could test with a mixing study to do a little more investigation. With an abnormal isolated PTT, we can also see this in patients that have lupus anticoagulant, which interferes with in vitro clotting tests, causing the prolonged PTT. You can have subtypes of von Willebrand's disease that can cause this. We'll talk a little bit in more detail about von Willebrand's disease in a minute as a bleeding disorder. And then more rarely, you can have things like factor 12 deficiency or deficiency in prekallikrein, which cause abnormal isolated PTT. These are notable because they don't predispose to a bleeding diathesis, which is just a way to say that these patients do not have a proclivity for bleeding. So you see somebody, their PTT is quite elevated, 70, 80, 90, and you're worried, oh, if I take this person to surgery, they're going to bleed. But if they have, say, a factor 12 deficiency, there's actually no good evidence to support that they're more likely to bleed or they have a bleeding disorder. And you could proceed with normal intervention and potentially prophylactic anticoagulation as you would in somebody that had normal PTT. And it's really just a laboratory abnormality that's not causing clinical problems, essentially. So it can be good to know, especially because it can be a little bit scary to see those abnormal labs, but especially if they have a hematologist, getting reassurance that this is not going to be a clinical issue in the OR afterwards. It is notable if they have a prolonged PTT in this setting that monitoring PTT, if you did need something like a heparin drip, is not reliable. So in that clinical scenario, you'd need to use the anti-10A instead.
And just as a quick summary of that, Matt, to hit it again for the listeners, I think it certainly can get a little twisted thinking through PTT versus PT and INR. So abnormal PTT, intrinsic pathway, and a normal PT/INR, normal extrinsic pathway. So we have a intrinsic pathway abnormality, which could be from a factor deficiency like a hemophilia. First, it could be they're on some medications, obviously sort of heparin thing, or they could have an acquired factor inhibitor, an example being like lupus or something else going on. But be careful because sometimes some of these will not actually have a surgical relevance, like the factor 12 deficiency, once we start getting down more rabbit holes. Okay, so that's kind of first grid square.
That's exactly right. Second grid square, if you think about a prolonged PT, INR, and the normal PTT, again, check their med list. If they're on warfarin, that might explain your abnormality right there. You can see an abnormal PT-INR in the setting of vitamin K deficiency. You can see it in the setting of liver disease, as we had talked a little bit about earlier. And again, you can get a mixing study to look for factor 7 deficiency or an acquired inhibitor if you're still looking for underlying causes.
That makes sense. Extrinsic, just kind of warfarin or liver stuff.
If you have a prolongation of both, that could suggest something's going on in the common pathway, or in unusual circumstances, you have issues in the intrinsic and extrinsic at the same time. But we see this in more severe liver disease. We see this in more severe vitamin K deficiency, which I have seen. We see this in disseminated intravascular coagulopathy, or DIC, which is an issue with both bleeding and clotting, but we see quite severe coagulation study abnormalities in DIC. And deficiencies in common pathway factors are quite rare. Say an inherited deficiency in factor 2 is very unusual, but you could consider an acquired inhibitor to one of those common pathway factors as a potential etiology of this. And then the last box would be, I'm concerned my patient has a bleeding disorder for whatever reason, because of their history, because of what happened in the hospital, but the PT and PTT are totally normal. In those circumstances, you want to think about von Willebrand's disease, because there are many types or cases of von Willebrand's disease where, because it's an issue with von Willebrand factor, they're going to have bleeding proclivity, but a normal PT and PTT. You can think about those other platelet disorders that we mentioned briefly, like Glanzmann's, or you could think about something like a factor 13 deficiency, other more rare etiologies that we don't need to get into, but sometimes you can do more specific or focused platelet testing, a little bit beyond scope, but platelet aggregometry for functional testing of platelets. Are they working correctly? You can do genetic testing to look for inherited mutations. But if they have a normal PT and PTT and you're concerned about a bleeding disorder, start to think, could this be an issue with the platelets and that primary hemostatic process?
Nice. I love that, man. That 2x2 grid square with each of them alternating and building that diagnostic framework. That's a really awesome way to think about it. Let's move into some specific bleeding disorders now. So let's start with some of the most common, I think, Max. Let's talk about hemophilia A, factor 8 deficiency, the most common inherited factor deficiency, followed by factor 9 deficiency, also called hemophilia B. This is an X-linked bleeding disorder characterized by a deficiency or complete lack of factor 8 or 9, if we're talking about one or the other, A or B. 9 is also colloquially called Christmas disease. The stupid way I remember that is I'm old enough to love the movie Dumb and Dumber and Lloyd Christmas. So I always picture Jim Carrey for this. But patients who have one of these hemophilias are absolutely prone to bleeding. And as a kind of secondary hemostasis issue, you would often see hemarthroses in a younger patient bleeding into the joint. unless, again, you have an acquired factor inhibitor, in which case they often present as an older patient with abnormal bleeding. And these can be mild, moderate, or severe. I have heard anecdotally of an oral surgeon who almost had a patient die because the first surgery they had was taking out wisdom teeth and several liters of blood were lost. So remember, a lot of times the first surgery we do on somebody will be the first one they have. So, you roll the dice enough statistically, you may encounter one of these. If something is bleeding an abnormal amount, not like an arterial bleeding surgery, but just kind of oozing from everywhere, that should perk your antenna up. Going over some of those, how much bleeding is too much and when to give me a call afterward. Because if these do manifest, it can be mild if the issue is mild, but in these severe patients, it can be quite impressive. I have certainly seen trauma with really impressive hematomas in young children that doesn't make sense with the story. And, I usually think about and rule out abuse. That's required by law to kind of be thoughtful and work with your emergency room. But I start to ask questions, and I went through this scenario, and the mom told me the three brothers also have nosebleeds that need to get burned all the time. She has some sort of bleeding disorder. Her husband does. Her grandfather does. And all these things kind of feed into, hey, we need to get a hematologist on board before we do a surgery to do something so that we don't harm a patient. Taking care of patients with this, we can replenish that treatment factor, whatever they're missing. There's recombinant factors. There's many products that you can give somebody for hemophilia A or B, including concentrates from the plasma or combinations. Those are quite expensive. Off the top of my head and from what I've heard, a single dose might cost anywhere from $7,000 to $10,000. I've worked with hematologists to do those infusions myself before surgery. Typically, it might be like 30, 60 minutes before you start the IV, you give them this, and then you can move on and do what you got to do. But there's definitely some strategies to work out with the team about prophylaxis in high-risk individuals to help prevent that. And so our goals kind of perioperatively, if we're doing surgery on somebody with hemophilia A or B, is to perioperatively replace that factor with recombinant factor generally, to get those levels to about 80 to 100% prior to surgery, and to maintain it about 50% of the level for 1 to 2 weeks postoperatively. They're pretty short half-lives, administration, 20, 30 minutes, sometimes a little bit longer. And if the patient has factor inhibitors, those can inactivate the infused factors that you'd be giving them. So it might involve the use of a bypassing product. And those are things, for an example, called factor VIII inhibitor bypassing activity, or other types of very specific agents you would give somebody to help get around that to make sure you can do surgery. And kind of when we're thinking about some of the number deficiencies, factor 11 deficiency is a pretty rare autosomal dominant condition, strongly associated with Ashkenazi ancestry. Max or Grant, you guys got any thoughts on the hemophilias, particularly 8 and 9 or A and B?
Sometimes when you're seeing a patient in the emergency department or in the more acute setting, you don't have all the history. And so sometimes we use those bypassing products in those circumstances if we don't know their whole history, but we're worried about an underlying bleeding disorder and it's not clear if it's from something like an acquired inhibitor or something that they were born with. Often these hemophilia patients, if it's an inherited deficiency, will be identified as children and have a hematologist for life. But as we all know, you see patients in the hospital that maybe don't come with a complete history and you're operating on some more limited clinical information, in which case giving a bypassing product that's activated prothrombin complex concentrate has activated clotting factors that are downstream of 8 and 9. So even if they had a circulating factor 8 inhibitor, it doesn't matter. The activated part of the clotting cascade will bypass that and help to treat any active bleeding issue until you can really get some more history and figure out what's going on with the patient.
That makes sense. You kind of hedge your bets until you figure out what's up, because if you go the other way, it's not going to do anything.
Exactly. Yeah. So if you're operating in limited clinical information, sometimes it's best to just give the thing that you know will work for everybody until you can really make more precise recommendations.
Nice. Let's see. Next up, let's talk about von Willebrands. Everybody's favorite, very common testable material. common to see these patients too. I have seen a number of these, and I'll describe some particularly interesting ones I've taken care of. But Max, you want to start taking us through good old von Willebrand's disease?
Definitely. So most common bleeding disorder, something I think a lot of us are going to, at some point in our careers, come across, whether it's in the surgical realm or otherwise, affects up to 1% of the population. And the most common type 1, is autosomal dominant, but it has variable penetrance, which can make the clinical symptoms really vary pretty widely from person to person. Somebody who has mild proclivity for bleeding might be a circumstance that you see, and then other people might have more severe bleeding presentations. So it can be pretty different from patient to patient.
Max, let me interrupt you. There is a lateral thinking that I like to do with certain disease processes if I'm getting a history, and most OMS think in this way. When we have a patient with asthma, we like to ask a ton of questions about it, trying to ascertain how bad it is, right? Have you ever been hospitalized or intubated? How often do you use your inhalers? What causes it? What makes it better? Similarly, a lot of the bleeding issues, I think about this with sickle cell patients, what causes it? How often are you hospitalized? Would this, not only for von Willebrand's, but are these common good questions to kind of dive into to help to understand some variable penetrance? Because like you said, in von Willebrand's, you can have quite a variable, but I imagine even with a lot of the other ones you might see, there's still this, oh, the doctor mentioned it, but I cut myself at, heel spines. I've had surgery before with no issues. Is there a lot generally of just kind of variability in how it on the ground affects patient to patient with these?
Yes. And it's, I think, a really important point, not just with von Willebrand's disease, but bleeding conditions in general are so important in terms of history and taking the right clinical history and understanding what's going on, because it can be really challenging, especially if you're meeting a patient for the first time, to understand if they actually do have a bleeding disorder. You might have some more vague clinical history about things that have happened in the past, that the patient remembers some things that happened, but maybe some of the details are lost and you don't have all the records. So understanding bleeding situations that they've been in, prior surgeries that they've had, how the surgeries have gone, any complications that they've had, family members, have they had bleeding issues? Specifically, what were those? What interventions were required are super important. And then understanding with von Willebrand's disease, we can do more specific testing to look at von Willebrand factor activity and defining the subtype. But a lot of it does also come down to the history, understanding your individual patient and their severity of their von Willebrand's disease and proclivity for bleeding can really help you make some individualized clinical decisions and thinking about what type of medicines might be needed if they're in a scenario requiring therapeutic intervention for bleeds.
I appreciate it. I thought that was just a very important point to hit. It's like everybody's different, every disease is different. And we should think like that about all these disease states that we're talking about. But please continue on with the pathophys of von Willebrand's, my friend.
Yeah, I think it's super important. We get patients in clinic for question bleeding disorder. And before you even start the testing, the history is just absolutely critical. So for von Willebrand's disease, we briefly discussed earlier, von Willebrand factor is synthesized in endothelial cells and helps with hemostasis by binding platelets, helping with that primary hemostatic process, as well as it acts as a stabilizer for factor VIII, which, as we discussed, is part of the intrinsic pathway. Factor VIII, without von Willebrand's factor, has actually a very short circulating half-life. So von Willebrand factor is a key piece in helping keep factor VIII around and able to help with the clotting cascade or secondary hemostasis. So von Willebrand's disease can potentially impact both, which is why you might see some variability in the testing that's done, say measuring a PTT. These patients often, because von Willebrand's factor is part of that initial binding of platelets, will present with things like mucocutaneous bleeds, gum bleeds, brushing their teeth, or if they get a cut, it takes a long time for that to be able to stop bleeding. But depending on the type of von Willebrand's disease, they can also have deeper tissue bleeds, more similar to somebody, say, with hemophilia, if it really is impacting that factor VIII activity. And in terms of testing, you can get a von Willebrand's disease panel in a lot of centers, and that includes the von Willebrand factor antigen, so the amount of von Willebrand factor present in the plasma. You can test the von Willebrand factor activity. You can also check the factor VIII activity. So that gives you an initial sense of what's going on. And then more additional specialized testing is available depending on the subtype. And that also includes genetic testing for specific mutations. And I wanted to quickly talk about the three main types of von Willebrand's disease. This is probably something that I think is nice to know at a higher level, but committing the details of each subtype to memory may be a little bit beyond scope, but it's nice to know that there are three types of von Willebrand's disease, and in broad categories, how that might play out in a clinical scenario. So by far the most common, over 70% of cases are going to have type 1. This is the autosomal dominant variable penetrance, and it's a quantitative defect in von Willebrand's factor. So it's driven by a partial decrease in the normal functioning of von Willebrand factor, and that's really what drives the proclivity for bleeding in these patients. Type 2, on the other hand, is a qualitative defect, and it's a problem either in factor VIII binding or defective platelet adhesion. And there are several subtypes of this type that exist, including 2A, 2B, 2M, and 2N, where 2A impacts the way that the von Willebrand factor binds to platelets. 2B is when the von Willebrand factor has too high affinity for platelets. It leads to thrombocytopenia and bleeding. 2M has decreased platelet adhesion, and then 2N has a marked decrease in binding affinity for factor VIII and can sometimes look a little more like hemophilia. I think this is something that, if you're in that clinical scenario, is always good to look up and re-review, because it's a little bit nuanced and complicated, but just to know that there are subtypes of type 2 von Willebrand's disease. And then type 3 is often the most severe. It's also a quantitative defect, but in this case, it's a near absence of von Willebrand factor. It's pretty rare. It'll present in childhood. And because you have near absence of von Willebrand factor, these patients have a high proclivity for bleeding. They also have very low factor VIII and will often look like a hemophilia A patient with deep joint bleeding at a young age. And the testing for von Willebrand's disease can often tell you which subtype they might fall into with that basic panel, just by the ratio of von Willebrand factor activity to antigen, where in a type 1 or a type 3 patient that has the quantitative defect, the activity to antigen ratio is going to be a little bit higher, versus in the type 2s, that ratio is going to be a little bit lower because it's a qualitative defect.
And then it does come up in places. So I always think about the specific name for one of those tests of von Willebrand's activity, a ristocetin cofactor assay. So I think that's just another specific name. Remember, there's many other weird names and subtests, but that one stands out in my mind too, a ristocetin cofactor assay, looking at the von Willebrand's activity. And the next kind of phase of this, I want to mention, this can be acquired as well. One can acquire von Willebrand's. I did not know that until I thankfully averted a potentially catastrophic clinical situation. This is much less common to get acquired von Willebrand's. You can get it with myeloproliferative disorders or lymphoproliferative disorders, autoimmune conditions, or where I saw it, it's associated with hypothyroidism, because low thyroid levels can decrease von Willebrand synthesis. I had a gal who I was going to do an open TMJ surgery on, and she didn't have any type of heme issues. She had hypothyroidism, I saw her maybe 6 weeks later, that pre-op morning for surgery, and she had bruising unusually kind of on her arms and different places on her body that wasn't there on examination. I started asking her about it and said they, just kind of came on, and a little bit of other bleeding history where the bruises were, kind of impressive. So I canceled the surgery and I had her referred to hematology, and thank God I did, because she had a pretty bad acquired von Willebrand. So don't forget, these things can just kind of happen. And, preoperatively before surgery is still a time when you can look at folks and potentially catch things. Grant, I don't know, you have any stories like that or things that stick in your mind, that kind of situations? I know that when they happen to me, they kind of stay there forever, and you always kind of think about stuff like that afterwards.
No stories off the top of my mind. That's a great story to hear from for you, to be able to know that can be acquired and the various things that can cause that. But yeah, like you guys are saying, it seems like it's one of those things that you have to get a good history on, because there is a lot of variation on how bad it can be and all that type of stuff. Usually it seems like when they get to us, it's all figured out by now and they're all prepared, but not always the case. So again, just coming back to that history and a lot of good questions and getting into it before doing any cutting.
Yeah. A bunch of weird new bruising or, stuff around there. Probably a good idea to figure that out before you do an invasive surgery.
Yes.
How do you think about treatment, Max, for patients like these? How are these patients managed, and how should we think about that?
There are a couple of therapeutic options in these cases. One medicine that we often reach for is called desmopressin, or DDAVP, which is a synthetic analog of ADH. And it works by promoting the release of von Willebrand factor from endothelial cells. And this can be a good option for folks with type 1, especially for just minor bleeds, or if they're undergoing minor procedures. You can use DDAVP in these patients, but these are folks that will need to have a test dose done in the outpatient setting first, where you give the DDAVP, say, in the clinic, and you get a baseline von Willebrand factor activity pre-administration and then a post-DDAVP activity level, and you ensure that it leads to an adequate increase in von Willebrand factor activity, so that when it comes to undergoing that minor procedure, or if they showed up in the emergency department with, I've seen a patient with a minor sports injury that had a history of von Willebrand's disease, and we saw that they had had the DDAVP test dose by their outpatient hematologist and felt pretty comfortable giving it, knowing that it would lead to an adequate rise in their factor activity, can be a good option to use desmopressin here. We also have von Willebrand factor replacement. Multiple preparations of this exist. Often one that we reach for is called Humate-P, which is plasma-derived von Willebrand factor concentrate and also contains factor VIII in addition to von Willebrand factor. This is the go-to for all patients with any major bleed, anybody undergoing major surgery. It's also the treatment of choice in most patients with type 3 and all patients with type 3, even for minor bleeding or minor procedures. If you think about type 3, they have a near absence of von Willebrand factor. So giving desmopressin to move von Willebrand factor out of endothelial cells just isn't a viable treatment strategy in those folks. And this is where understanding the type, is it type 1, type 2, or type 3, can be helpful for the treatment strategies that you're thinking about implementing. But when in doubt, again, sometimes you're working in a more emergent clinical scenario. Somebody is coming in for more urgent surgery that needs treatment. You hear, oh, they have a von Willebrand's disease history, but you don't know what type. You don't have access to their outpatient hematology records. They don't know what type. When in doubt, you can give them von Willebrand factor replacement, knowing that it will be a good treatment strategy for all patients, rather than DDAVP, which is a little bit more nuanced for specific patients that you might see. There are also adjunctive treatments that you can use with several hemostatic agents to help control bleeding. And Andrew, I was wondering if you wanted to take us through a few of these other adjunctive therapies that you can use in some of these patients.
I do also want to highlight that mechanism that you touched on. Why and how does DDAVP work? It releases von Willebrands from the endothelial cells. So if it's not there in a type 3, it ain't going to work. And usually this can be intranasal. I actually didn't look at the dose for this episode off the top of my head. I think it might be 150 mics is a squirt in the nose. But good thing to think about, right? DDAVP is a way we can release von Willebrands from those endothelial cells. Humate-P, very common blood product used, and it has von Willebrands and factor VIII. So if we're trying to replace one or both of those, that could be a really good thing to reach for. I have done surgery on a patient with 2M once. That was the category 2 for von Willebrands I've ever treated. And the same thing, I think I infused her with Humate-P and then did the procedure, and she was on some medications from her hematologist afterward, and she did amazing. To wrap up kind of this episode, we wanted to touch kind of OMS-specific hemostatic agents. One should think about hemostatic agents just like any of the drugs or medications that we use. If you're going to use it, you got to know everything about it. So I just wanted to touch on some of the most common ones, some of the ones that I like and use. So first up, gel foam, very common. It is a porcine-derived collagen that served as a scaffold for a clot. You can also mix it with thrombin for some more efficacy to jumpstart the coagulation cascade. Surgicel, right? Another very common one. It is oxidized methylcellulose. It brings platelets and precipitates fibrin to help form a clot. It has a very low pH as it's degrading, about 2.5 to 2.8. And you want to be a little bit careful with it around nerves, which I always found ironic because we use it a ton in neurosurgery, but I generally don't like leaving Surgicel in a patient. I do not leave it on an exposed IN. It can delay healing with that low pH as it degrades over the next 1 to 2 days. Collaplugs or collatate, right? Type 1 bovine collagen. We have cross-linked cartilage and collagen, and it stimulates platelet adherence and aggregation. Similar in that camp, maybe a little less commonly used Avitine or microfibrillar bovine collagen. It binds platelets and aggregates them for clot formation. I really use it when I'm doing anterior iliac hip harvests. I kind of fill the big chunk of hip that I take out with usually Avitine and gel foam. I don't use it too much otherwise than that. And let's not forget just thrombin, right? It can be very effective, definitely a little bit more expensive, a little bit more accessible in hospital. But you can add thrombin on any of these agents to help jumpstart that coagulation kind of lower down. Thrombin being factor 2. Tannins, right? In tea bags. Why do we tell people as an adjunct you can bite on several tea bags and hold pressure for 20 or 30 minutes? That tannic acid can act as a vasoconstrictor, which allows temporary clot formation. So that can be very effective. Flow Seal, or there's other things like Surgiflow. There's a lot of brand names. I love these products. They're typically a liquid agent that is a gelatin matrix, along with things like human-derived thrombin, as well as calcium chloride. They have usually an expansion coefficient, often 10 to 20%. But the way I think about these is it's like liquid gel foam with thrombin in it. So it's a great thing to put into surgical sites that are maybe a little bit more bleedy, things like muscle, or, if you're closing a site, you've had a fair amount of blood loss. So I love these type of agents. I use them frequently in the operating room. Mouth rinses, right? These can be incredibly helpful. Some of the patients that I've taken care of who require lifelong anticoagulation, I can still think about these patients with protein S deficiency, protein C deficiency. We bridge them for surgery. We're taking out teeth, doing hybrids, double arch reconstructions, things like that. Afterward, prescribing them one of two agents, the first being aminocaproic acid mouth rinse, Amicar. It's an antifibrinolytic agent and a clot stabilizer. It inhibits plasmin. It can be very effective. You can write this for as needed as for bleeding afterward. You can also have them prophylactically use it a couple times a day, just gently swishing and spitting for about a minute in their mouth. Conversely, we also have TXA mouth rinse, tranexamic acid. So we can use this in surgery, not the mouth rinse, but TXA itself. Personally, there's not great data. There's a lot of studies that I've seen that are smaller. There are some studies that do support this, the use of TXA in our major surgical cases, really reducing intra-op blood loss. The majority of time I'm doing major surgery personally, like orthodontic surgery, I'm usually giving the patient TXA perioperatively. I think the literature is still evolving on that, and I think we'll see more of it as we move forward. But you can ask for TXA to be made into a mouth rinse after surgery. The tricky thing is most hospitals don't have this on formulary, so you often need to engage a compounding pharmacy or talk to a pharmacist specifically because they're not going to understand what you're asking for. But if you're going to ask for it, you want a 5% TXA solution. And like we said, TXA inhibits plasminogen being converted to plasmin, thus stabilizing the clot. TXA is about 8 times stronger than Amicar, the aminochloroic acid mouth rinse. I love TXA mouth rinse. I think it is incredibly effective. My wife, who's an ER doc, and a lot of my ER friends will use it routinely because they have TXA in the emergency room to put on gel foam or other agents and use to try to help bleeding mouth patients. So it gets used a lot by other specialties, even more so than us. And just to be a little bit more specific, TXA, remember, it's a synthetic analog of lysine and inhibits fibrinolysis by competing with fibrin for the lysine binding sites in plasminogen. Grant, any thoughts or comments about all those things? I don't know if you have a personal one you like to use, or I found the mouth rinses to be really helpful in these anticoagulation patients after surgery.
Yeah, those are super helpful. I appreciate you discussing those because it's an issue to get those if you're like just dealing with a regular pharmacy. But I mean, personally, I'm using gel foam, collagen plugs, oftentimes wrapped in Surgicel like every day. I mean, for a lot of different things. I do a lot of PRF, so platelet clots in like lower third molars, and then like a collagen plug soaked in PPP. I mean, just all sorts of stuff to stimulate clots. But yeah, really helpful. Good review.
Yeah, it's like, especially, for the residents out there, those you got to know absolutely cold inside and out. And just to finish, I did want to mention a couple things that I think are really good to look at. And those are the CRASH trials. Those are abbreviations, but you can look up CRASH 1, 2, and 3. I'm not going to talk about CRASH 1. It deals with essentially steroids in settings. But the CRASH 2 trial looked at TXA in bleeding trauma patients. These are gigantic trials. The CRASH 2 trial, for example, looked at about 20,000 patients over 274 hospitals in 40 countries. Giant randomized prospective trials. And it looked at seeing if the early administration of TXA affects death or transfusion requirements in bleeding trauma patients. And what they found is a substantial decrease in mortality. It was highly cost effective if given in the first 3 hours. So the CRASH trials were really these monumental studies that brought TXA into the mainstream. And I think it's important to understand where this stuff comes from. The CRASH 3 trial looked at using TXA in head injury patients. And what they found, a similar kind of cohort, gigantic study, they found that patients with mild to moderate TBIs, there was a significant reduction in mortality and issues. It wasn't so effective in severe TBI brain bleed patients. And the CRASH 4 trial, which is kind of ongoing right now, is looking at intramuscular injection of TXA after TBIs to start looking if that can lead to better outcomes. So those are really good things. You don't have to read the studies, but check out the abstract so you have an idea about where all this TXA stuff is coming from. And then you can see, there's a lot of stuff in the Journal of Oral Maxillofacial Surgery and others, definitely smaller studies, but kind of focusing on TXA in our world. But those studies really brought it into the mainstream, and that's why it's an agent most of us are familiar with using at these points. Let's see, any final thoughts, Max or Grant, from kind of this initial episode where we're hoping to lay out those basics of kind of testing workup and some of the most common bleeding disorders. We'll move through some in the subsequent episodes, things like anticoagulation, looking at malignancies, and a lot of the other aspects of hematology that are, very important for us to understand and hopefully helpful reviews for everybody.
I am excited for those additional deeper dives into anticoagulation, clotting, and other hematologic issues that will be fun to talk about. I wanted to also just take a step back. I know that we talked a lot about specific tests that we're doing, specific conditions that you might see that can predispose patients to bleeding and may impact perioperatively how we're thinking about surgery. But if you have a patient that is bleeding or you're concerned about bleeding, thinking about the primary hemostasis, secondary hemostasis, forming that clot can be a nice framework to think about how to intervene, because there are several steps in which we can give medications and use therapies to help patients in those circumstances. Is it a primary hemostasis issue? Is this patient thrombocytopenic? We check the CBC, the platelets are low, we can give them platelets. Is it a issue in the coagulation cascade? We can replace factor, we can give them product, whether it's FFP or something more specific, helping to reverse any coagulopathy that we appreciate on testing. Once they have a clot formed, and can we intervene on clot breakdown, help make that clot stronger and last longer using things like TXA? So approaching our interventions with the understanding of that framework can often be helpful, knowing what products or interventions we can give. And if there are other aspects of that pathway, often we need to do more than one thing at once in somebody with severe bleeding that we want to reverse. And so those are several steps along the bleeding, clotting continuum that we can act on to help folks.
It's been fantastic. I really appreciate you guys running through this. You guys just break things down in a very simple, easy to understand way. So I'm looking forward to the next few episodes. I think this is great.
Awesome. Well, thanks, Grant, and appreciate all you listeners out there, and stay tuned for all the subsequent episodes.
That's right. Get excited for hematology, folks. Let's do this.
You nerdy like us and love this stuff.
Awesome. Well, thank you so much. I appreciate you guys.
Thanks, Grant. Take care.
Thanks so much, Grant.
Thank you so much for listening to this episode of Everyday Oral Surgery. For more information on these podcasts, please visit everydayoralsurgery.com. I love feedback and would be very grateful if you would reach out to me via my email, grantstuckey@gmail.com, and let me know what you thought of this episode. Or you can text me at 720-441-6059. Additionally, if you have any topics you'd like to hear about, or if you would like to be a guest on the podcast, please email or text me. I found many of my interviewees through people who have been contacting me and have been listening, and I've gotten so many great ideas for more podcasts, and that's what helps keep the podcast rolling. So I really appreciate you making that extra effort and helping me out with feedback and knowing what to do next on the podcast. Thank you so much.